Good evening, everyone. My name is Michelle Galazewski. I am a Partner Relations Director with Eversight. And on behalf of Eversight, I would like to thank you for joining the second program of our webinar series, Management of Corneal Ectasia. We are excited to have you all with us this evening. Just a few quick housekeeping notes I'd like to cover before we begin. In an effort to eliminate all background noise, all participants will be muted throughout the duration of the webinar. If you would like to ask a question, you may do so by typing your question into the Q&A panel at the bottom of your screen. We will address all questions at the end of the webinar. At this time, I would like to introduce our speaker for this evening, Dr. Shahzad Mian. Dr. Mian is a professor of ophthalmology and visual sciences at the University of Michigan Medical School, Kellogg Eye Center, Michigan Medicine. He also serves as the department as Associate Chair for Education. He earned his medical degree in 1996 from the Emory University School of Medicine and then completed a residency at the Wills Eye Hospital of Thomas Jefferson University in Philadelphia. From 2000 to 2002, Dr. Mian was a fellow in cornea and refractive surgery at Mass Eye and Ear, Harvard Medical School. He joined the Michigan Medicine faculty in 2002 as a clinical lecturer in ophthalmology and visual sciences and was promoted to associate professor in 2010. Dr. Mian, you can begin.
Thank you so much. It's certainly a great pleasure to be part of the Eversight webinar series. I hope that I can, in the next half hour or so, review some of the options that we have in managing our patients who have corneal ectasia. I can forward my slides. There we go. So what is corneal ectasia? And I'm going to start sort of with the basics to review definitions of what we're talking about. Ectatic disorders include keratoconus, which is a non-inflammatory thinning of the corneal stroma, resulting in abnormal conical shape of the cornea. Keratoectasia is defined as progressive corneal steepening and thinning, which is caused by treatment with excimer laser with refractive surgery. Keratoconus tends to be bilateral, but is often asymmetric. It is unilateral in rare incidences. There is evidence to suggest that it progresses over a short period of time in most people. It also is associated with progression usually in the teen years and stops progressing at later in life. It's associated with eye rubbing and conditions that promote eye rubbing, such as atopy and connective tissue defects. The prevalence of keratoconus is somewhere between 50 and 200 per 100,000. And again, the onset tends to be in puberty with progression until the third or fourth decade. However, this has been changing, and with our perspective on this has been changing as we have paid more attention with corneal imaging techniques, as well as now the availability of cross-linking, and we tend to see patients earlier and earlier than we did in the past. Family history is found in 8 to 10% of patients. It is thought that corneal ectasia develops because of altered biomechanical elasticity of the cornea, which is related to loss of the anterior stroma. And the anterior stroma normally is highly compact and is responsible for providing greater biomechanical strength to the cornea and allows for the cornea to be more resistant to mechanical deformation. There may also be a pre-existing corneal abnormality, such as in keratoconus, where there is likely intrinsic collagen weakness. And certainly, with respect to ectasia after refractive surgery, there are tectonic effects of creating a flap, especially if the flap is irregular or too deep. There are genetic studies which indicate a number of genes that are linked to keratoconus, including a number of transcription factors and collagen defects. However, there's no one gene that can be associated specifically with keratoconus. Genetic testing can be available with a panel of genes that may be suggestive of keratoconus. Ectasia after refractive surgery results in progressive corneal steepening centrally or pericentrally, which symptoms including increase in myopia, astigmatism, which is often irregular, presenting initially with loss of uncorrected vision and then best corrected vision with eventual thinning of the cornea. The prevalence of disease does vary quite a bit depending on which study you look at. If we go back to looking at the estimate of keratoconus being 50 to 200 cases, and looking at refractive surgery estimates early in the course of when we started doing LASIK, the range was somewhere between 0.1 and 0.6%. But if that were the case, even back when we had LASIK about 10 years ago with numbers, we would have a lot more cases. So the prevalence after LASIK is much lower than what these initial studies estimated. And it's partly because after LASIK was approved in 1997, we did see a spike of cases published in the literature. And here's a series from Emory, which indicated high numbers, which stabilized even back in the early 2000s. Ectasia after LASIK can present with a mean time to onset at 15 months, with 25% of patients presenting within 3 months, 50% presenting within 12 months, but there are 10% of patients that can present after 3 years, and has been reported even as much as 10 years after LASIK surgery. So how is corneal ectasia diagnosed? Well, a clinical presentation used to be the only way we really diagnosed keratoconus, where again, there's loss of uncorrected vision, often complaints of visual distortion, including monocular polyopia, ghost images, glare and halos associated with it. The refractive changes can be detected on retinoscopy with scissoring of the light reflex, again, progressive refractive error with induced astigmatism and eventual loss of best corrected vision. Clinical signs include iron deposition and a ring formed in the basal epithelial layer of the cornea, mechanical stress lines in the posterior stroma called Vogt striae, and certainly stromal thinning at the apex of the cone. With more advanced disease, patients can develop apical scarring, and that is usually due to mechanical stress on the anterior stroma, which is already weaker. But it can also be induced by the contact lenses patients wear in treatment of their keratoconus, and this is usually superficial, almost like a Salzmann's nodule, which can be relatively easily scraped. Other clinical signs that are used to describe late stages of keratoconus include Munson sign, where there is protrusion of the lower lid when patients looking down because of the advanced nature of the cone, or the nasal conical reflex called Rizzuti sign. Of course, in very late stages, when there's a break in Descemet's membrane, patients can present with corneal hydrops. Ectasia diagnosis has been described in the literature with many different classifications. The Amsler-Krumig classification was one of the early ones, which uses information from the patient, including refraction. So this is spectacle refraction, implying that the more irregular astigmatism there is, that more suggestive of keratoconus. A steep manual keratometry reading of more than 55 for advanced stages, development of corneal scarring, and thinning of the apical cornea at the apex. So these are, again, clinical factors that can be used to make a use the staging category. But again, this is based on information that's been around for many, many years. Form-fruit keratoconus is a term that we often use to describe patients who are asymptomatic, have an increased family history of keratoconus, but have a normal slit lamp exam and only an abnormal topography. So this may be really just keratoconus just diagnosed early, where their slit lamp findings are not present and they're asymptomatic. Topography is a great tool to be able to screen and diagnose keratoconus. There are many different indices that have been developed based on criteria, including inferior superior ratio of difference in keratometry of greater than 1.4, central steepening greater than 47, and ratios calculated from there. Corneal tomography has improved our understanding and diagnosis of keratoconus by now using a slit beam approach to assess not just the corneal curvature, but also to look at the posterior layer of the cornea, where this posterior elevation map is with being greater than 40 microns may be indicative of keratoconus at an earlier stage. This map also provides us with pachymetry reading, allowing for earlier detection. Shine fluid imaging is another way to perform tomography where these corneal images can allow us to not only obtain corneal curvature, but also corneal thickness, anterior and posterior elevation maps, and therefore predict presence of keratoconus at earlier stages. Here's just a map, a pentacam map showing all these findings where there is, on the current topography map, there's inferior steepening, there is thinning at the apex of the cornea, and there's elevation both on the anterior and posterior surfaces of the cornea. There are many references to how to assess keratoconus even using tomography. One of the more recent ones has been the Bell and Ambrosia Enhanced Index, which uses slightly different criteria. So normally when we're looking at anterior and posterior elevation, we're assessing this elevation relative to a best fit sphere of 8 millimeters centered on the cornea. However, the enhanced reference surface, or the Bell Ambrosia Index, uses the thinnest portion of the cornea and a 3 millimeter zone around that to estimate the anterior refractive curvature and the posterior radius of curvature. This also adds in corneal thickness and best corrected vision to determine a scoring system to allow us to predict who has keratoconus and also stage progression of keratoconus. Risk factors for keratoconus, of course, include abnormal preoperative topography findings. This includes, again, a central corneal curvature that's greater than 47, the difference in inferior superior ratio, again, findings on tomography, including the orb scan with posterior float. Patients who are high myopes, defined by -8 or more. Patients where preoperatively we can predict will have a thinner residual stromal bed. Historically, we've used a number of 250 microns, but most people now tend to use a number of 300 to be on the conservative side. Patients who have preoperative pachymetry less than 500 microns. Younger patients who age less than 30. Patients who have a family history of ectatic corneal disease. And now a more recent index using a potential tissue altered, which is a measure of the predicted flap thickness and amount of tissue that's ablated. And if that's more than 40% of the total central corneal thickness, patients may be at increased risk for developing ectasia. So how is ectasia treated? Well, traditionally, keratoconus and ectasia is treated primarily with glasses in many patients when we can. However, with progression, this is not possible and patients require some form of contact lenses, but there are surgical methods that can be used to manage keratoconus. There are many different options for using contact lenses. There are some specific silicone hydrogel designs which are helpful in terms of how they are structured to correct the irregular astigmatism in patients and allowing them to be able to manage milder forms of keratoconus with soft contact lenses. As the disease progresses or in more advanced disease, gas permeable contact lenses are often needed and are able to correct most patients for vision correction. However, some of the issues with gas permeable lenses are that they can be difficult to keep on fitting with more very advanced disease and can be uncomfortable for patients. Scleral lenses have really helped us change that because they can be fit over a very irregular cornea with no corneal bearing and no limbal bearing, which is safer overall for the cornea, especially with very steep corneas. There are certainly advantages of using scleral lenses, including comfort and improved vision. They can also allow for better stability of the corneal health, are reusable up to several years, and come in lots of parameters that can be modified and customized for the patient's corneal disease. The disadvantages are that there is certainly a learning curve for patients to be able to use them. They require special regimens for cleaning and can be quite expensive to use. We looked at our keratoconus patients at Kellogg Eye Center to see, of all the patients we were seeing, how many patients needed surgery and how other patients were managed. So in our series of patients where we had nearly 2,800 patients, only 90 needed keratoplasty over the 6-year period, which gives us a rate of about 3% overall. Patients who are more likely to need surgery included African Americans and patients with poor socioeconomic status. Patients who were not wearing contact lenses also had a higher rate of needing surgery. So the significant factors we found in our series were patients who actually were wearing scleral lenses had an 80% decreased hazard ratio of needing corneal transplantation. Patients who were wearing rigid gossamer lenses also had a nearly 64% decreased hazard ratio of needing corneal transplantation. Increased risk of keratoplasty, as I mentioned, was associated with African American race, having a steeper maximal corneal curvature with 1.8% increase in the hazard ratio for every diopter of increase in maximal curvature. So this would mean that if your corneal curvature increased by 10 diopters, you had an 18% increased risk of needing corneal transplantation. And again, socioeconomic status was a significant risk factor for needing corneal transplantation. So if contact lenses don't work for patient, what are our options besides keratoplasty? Well, we can consider intrastromal corneal ring segments, and certainly different forms of keratoplasty are indicated as well. There are two forms of intracorneal ring segments that are available. In the United States, it's primarily Intacs, which is actually now owned by Glaukos, and Ferrara rings outside the US. These work as passive spacing elements, which help to flatten the central cornea by creating a shorter arc length of the anterior corneal surface. They do provide some biomechanical support for an ectatic cornea. However, they have not been shown to reduce any progression of disease. The advantages are that they're reversible, meaning that you can go back and remove them if there are any associated complications with them. They are relatively safe, and because they're not placed in the central cornea, they have less impact by themselves on the visual axis. However, the more centrally placed they are, the more glare they can induce. And studies have shown that they can reduce a spherical equivalent between 2 and 9 diopters. So they can overall improve visual acuity and improve contact lens tolerance as well by flattening the central cone. However, these are primarily indicated with milder degrees of keratoconus. They may help reduce scarring in patients because if there's a flatter central cornea, there's less likely to have rubbing against the contact lens and induce scarring from that. There is regression spherical correction over 5 years associated with these. So moving on to keratoplasty. Penetrating keratoplasty used to be the most common way we managed corneal keratoconus in advanced stages. However, these numbers have decreased over the years. The estimation was that nearly about 20% needed of all keratoconus patients needed corneal transplants over a 40-year period. And as I mentioned in our series, is only 3%, primarily because of the availability of better and better contact lenses. In last year's Eye Bank Association America report, of all the penetrating keratoplasties that were performed, which was about 17,000 in the United States, 14% were for ectasia. So unlike in the past, now we do have a form of being able to prevent corneal ectasia, and that's in the form of collagen cross-linking, which is used to stop the progression of corneal ectasia and preserve vision, and therefore reduce the need for keratoplasty and minimize adverse events associated with having procedures such as keratoplasty. Patient expectations may be that this may eliminate need for contact lenses or eliminate need for surgery, but that's not really the case. Our goal is to help stabilize the cornea, but certainly patients may reduce the need for contact lenses if you catch them early enough and they don't need them at baseline. And similarly for surgery, hopefully we can reduce the need for surgery by stabilizing the cornea. The way cross-linking works is that it increases the biomechanical strength of the cornea, and there are studies that have looked at tensile strength of corneal tissue when it's treated with cross-linking and have shown that it becomes stiffer. As you can see that visually from these pictures from the initial studies that were published related to cross-linking. In the United States, cross-linking was FDA approved in 2016. The FDA approved procedure is an epithelial off procedure which uses UV light and riboflavin for treatment. It's indicated for both progressive keratoconus and corneal ectasia. The protocol that's approved is the Dresden protocol, which was originally described for use for keratoconus, where the epithelium is removed in the central 9 millimeters, and isotonic riboflavin is placed every 2 minutes for 30 minutes. This is followed by irradiation for 30 minutes with riboflavin being additionally applied every 2 minutes. In the original series of patients, not only were they able to show that keratoconus did not progress, but over the follow-up time period, there was actually regression or flattening of the central cornea by 2 diopters, and there was an increase in best corrected vision by 1.2 lines. This has been shown over and over again in prospective randomized studies in the US and outside the US, with short-term and long-term follow-up at this point showing that there's improvement or stabilization in best corrected vision and improvement or stabilization of central maximal corneal curvature. Our experience has been similar in looking at patients both with keratoconus and ectasia at Michigan. We have also noted that when we follow these patients, there's improvement in best corrected vision and maximal corneal curvature. Complications associated with collagen cross-linking in the United States have primarily been associated with epithelial removal. Not only does this cause the obvious pain, but because there's a persistent epithelial defect, this can result in keratitis, haze, and reduced best corrected vision. The incidence of persistent epithelial defect is reported in the literature to be between 3 and 8%, where the risk factors include things such as higher fluence use, diabetes, history of Down syndrome, pachymetry less than 400, use of topical non-steroidals after surgery. Treatment is primarily associated with things that we use after when we're managing neurotrophic corneal ulcers or corneal abrasions that are prolonged, including bandaged lenses, lubrication, serum tears, and possibly amniotic membrane use with more persistent defects. Infectious keratitis, although has a low incidence reported after cross-linking, can occur, and the organisms that have been reported include a broad range, including gram-positive bacteria, gram-negative bacteria, fungi, acanthamoeba, and herpes. Sterile keratitis can also occur after cross-linking, and there's a higher incidence of this, being about 7.6%. This often responds well to topical steroids and is associated more commonly in patients who have ocular surface disease with an inflammatory component, including atopy and vernal keratoconjunctivitis. Patients have been reported with a full thickness corneal melt and perforation after cross-linking as well. Corneal haze can also develop. This is quite common early on, but it can persist and can lead to loss of best corrected vision, although that is not common. Risk factors for losing best corrected vision and persistent haze include age greater than 35, best corrected vision prior to cross-linking being worse, maximum corneal curvature greater than 58, and thin corneas below 400. Again, haze has been reported in a number of series. Most of them indicate that this occurs early and resolves without any significant loss of best corrected vision except for in rare cases. Corneal edema has also been reported after cross-linking, which often requires additional surgery and has been associated with even iris atrophy, which seems to suggest that this is really endothelial injury caused by use of cross-linking. We do know that in the safety studies that were initially done that there is penetration up to about 400 microns into the cornea, and therefore it's safer to not treat corneas that are thinner than 400 microns in order to avoid damage to the endothelium. What are good ways to prevent? Well, it's helpful to remove the speculum during riboflavin loading so that the cornea doesn't thin out. It's helpful to make sure that the equipment is properly calibrated, and really to make sure that the pachymetry is more than 400 microns before you start the ultraviolet light treatment. And that can be done through use of hypoosmolar riboflavin, use of sterile water, preservation of central epithelium. However, the current protocol has not been shown to be effective when the epithelium is intact. Some studies have reported use of contact lenses in the eye or cutting them in a shape to where it allows protection or increasing the thickness of the central cornea while peripheral cornea is treated, but this may also hinder stromal irradiation and reduce oxygen diffusion to allow proper cross-linking to occur. Treatment failure, when it's defined by a keratometry increase of more than 1 diopter over 12 months after cross-linking, does occur and has been reported in a few series. Risk factors for treatment failure, again, include things such as age, poor best-corrected vision, steeper corneas, eccentric cones, thinner corneas, and more likely to occur in the pediatric age group. There's some interesting data that's been published in Closed Health System. This is data from the Netherlands, which indicates that their rate of corneal transplantation decreased after they instituted cross-linking as a measure to help prevent progression of keratoconus. Of course, in the US, it's a little bit harder to show that because we have not had as many years to be able to show decrease in rates of corneal transplantation associated with it. So in summary, advanced diagnostic tools do allow us for earlier detection and management of corneal ectasia. Visual rehabilitation and corneal ectasia can be accomplished with use of contact lenses in the majority of patients. And collagen cross-linking really may help us change the natural history of patients' disease course and prevent the need for corneal transplantation. Thank you.
Okay, at this time, if anyone does have any questions for Dr. Mian, you can enter the questions into the Q&A box. The first question is, are anterior segment transplants commonly used in management of KCN, ALK, or DALK?
Great question. So yes, although in the United States, I think we've been behind the curve in adopting use of deep anterior lamellar keratoplasty. That is the preferred surgical technique when keratoplasty is performed for keratoconus. Again, fortunately, we don't have to do any transplants on most patients who have keratoconus, but DALK is the preferred method for treatment, surgical treatment of keratoconus.
Okay, next question is, do you use the same protocol for the keratoconus and post-LASIK ectasia?
Yes, so the Dresden protocol is used for both. It was FDA approved for both keratoconus and post-LASIK ectasia, and therefore that's what we do use for treatment of ectasia. It's the same protocol.
Okay, and then the last question is, how thin is too thin?
That's a great question because these patients who are more advanced are the ones that we worry about. And they often have thinner corneas. So the 400 micron thickness is what is required before you can start the light treatment. Therefore, you do have to get the cornea up to that thickness. So generally, we start with most patients who are already at a thickness of 400 microns before we consider cross-linking. However, patients who are relatively close to that, that is maybe around 350 or maybe even a little bit less, 330 to 350, you can increase their corneal thickness by using the hypotonic riboflavin from the very beginning. The standard protocol uses isotonic riboflavin, but using hypotonic riboflavin will thicken it up even in the first 30 minutes, and that may allow the thickness to get to 400 microns to allow the cross-linking to occur.
Okay, and the final question is, does cross-linking have any effect on the success of DALK?
It's a great question. I have not had the opportunity to do DALK after I've already cross-linked a patient. Fortunately, they've been relatively stable and we haven't been doing it long enough to have long-term data on that. But I would imagine that it should be a similar process with respect to performing the surgery. I do not have any personal experience with DALK after a patient has been cross-linked.
I would like to take the time to thank everyone again for joining us today. The webinar has been recorded and will be available on our website to view on demand. As a reminder, we are hosting this series every Wednesday throughout the month of May. So if you have not registered for our other programs, please consider doing so. You'll be receiving a follow-up email shortly after the webinar concludes, and it would be greatly appreciated if you would provide us with your feedback on today's session. A special thank you to Dr. Mian for serving as today's speaker and for providing us with your invaluable expertise on this subject. And I hope everybody has a wonderful evening. Thank you.
Thank you. Good night.